I know that you guys gone through a whole bunch of these, but we're just going to go over how we do it here and just tell you a little bit different and ask us questions because we're probably better. So Christine, who's my dosimetrist who helps contour, will kind of go in and out with me. So let's start. This is actually a stage 2B cervical cancer. And I've actually already put the contours on this patient, so we can just kind of go space to space. So this patient actually, we put ovoids in, right? And it was a stage 2. And the way we did it at MD Anderson, we actually put MRIs before the treatment. So we don't do MRIs with the treatment. We usually do our MRI about the 4th week into treatment to see how she's responded. And we use that MRI to help us contour the lesion on the CT scan, because as you know, the CT scan is not great. So we're just going to go kind of up and down, and please ask questions because I think that's the only way we can do this. So let's just start from the bottom and just talk about how we contour. So we really do start doing the rectum, right where we, right about where the rectum really starts. So you can see the pink right here is the rectum. And as you can see, we put a Foley balloon into our bladder. And this bladder probably was more full than we would normally do it. Normally we try to empty our bladder. And I guess the question is, do you do a full bladder? Do you do an empty bladder? And I know I've seen a lot of people put like 200 cc's into the bladder so that they push the uterus up and it pushes the bowel away. And in this case, you can see there wasn't very much bowel anterior. But I do know a lot of people put 200 cc's into the bladder, scan the patient, plan on that, empty it while they're planning, and then refill it with the 200 cc's. So I think you have to look at your CT to decide if you want an empty bladder or a full bladder. In this case, I think even an emptier bladder would have been better than what we have because the bladder is pretty, and now I'm going to show you the doses, but the bladder with it being as full as it is here, so you can see on sagittal how full the bladder is, it actually got hot because it was right next to the uterus. So I think if it had been a more empty bladder, we probably would have gotten less dose. But let's just start. So here you can see, here's my rectum, and here you can see my Foley here, and here's my bladder contour. So the bladder contour is in yellow, and I'm just going to highlight it so you can see it even brighter. But you can see here's my bladder contour, and here's my rectal contour right here in pink. So as we go up, and we're going to go up, and what I try to do is I try to contour on the axial, but I'm always looking at my sagittal and I'm looking at my coronal. But I'm going to tell you, I'm going to be honest, I'm more of an axial and a sagittal person, so I look to make sure both of it makes sense. So here's my rectal contour, and here's my bladder contour as we go up. And right now you can see this is all packing. So here's my ovoids, and here's my flange, and this is all packing. So we're just going to go up. And you can see the line as we're going up. Bladder right here, rectum right there. And we keep going up, and you can really see how clearly, and there's packing probably. I may have actually over-contoured the bladder a little bit right here. So you do wonder if that bladder could have just not gone up just a little bit more up there. But here we go to the bladder, and this is going to be the contrast in my Foley bulb that you're seeing right now. So again, we're going up. Here's my rectum. As you can see, here's the rectum, here is the ovoids. As we go up, now we're hitting my ovoids, and my ovoids, we still use shielded ovoids here, and I know a lot of people don't, especially if you're going to do CT, it's probably better not to use shielded ovoids. If you do use shielded ovoids, and if you're doing a CT scan, if you can get like an Omar filter, that would help by taking the scatter away from the ovoids. But most people are not using shields at all when they're doing CTs. So you can see we contour the entire bladder and we contour the entire rectum. So we're getting closer and closer to the cervix, and you can see here we're getting to the cervix. So here's getting right to the top of my ovoids, and you can see right there. We're right, so you can see if we go down one more, if we go down on my sagittal, we go up, you can see where we're right at the top of the ovoid. So I do contour a little bit of vagina right there. And as we keep going up, here is my vagina right there. And this is like probably the anterior lip of the cervix. And I'm contouring here the tandem, and right above is my HR-CTV, which is the cervix. So let me, just a couple of things to highlight, and I am going to get my dosimetrist here because I got to go see this patient, but I'm going to have her continue. What I do, and please talk, because I can't, I can't see you guys, so I don't know what you're learning and not learning. But we do put a measuring line from the top of our flange, if that's where the cervical os is, from the top of my flange up to 3 cms, because the cervix length is 3 cms. Now, if there's uterine involvement, you're going to go more into the uterus, right? But if there's no uterine involvement, the normal cervix length is about 3 cms. You can always measure it on your MRI. But if you don't have an MRI, that is the standard, is usually 3 cms. So we do usually measure, and I'm going to show you, let me see if I can do this. Measure. So what we really do is we will measure, we will go from the flange up 3 cms, and they actually will put a line for me that tells me it is 3 cms. So if you can see, this is exactly, if you look at my sagittal, it is exactly 3 cms. So we do make sure that our cervix, unless there's uterus involvement, is 3 cms in length. So that's, and we will measure that, and we really don't try not to go past that. So there you go. So that's, and you can see, that's exactly 3 cms. Now, we will load the tandem past that, but my HR-CTV, which is going to be the disease that's left at the time of brachytherapy, and the entire cervix is going to be about 3 cms in length unless there's uterine involvement, okay? So that's, we always put that line in there, so you can see it's exactly 3 cms. So as we go up, as you can see here again, and now we're stopped doing this, but we used to put platinum seeds at the 6 o'clock and at the 12 o'clock position. So you can see this is one of my platinum seeds that again shows me where that anterior lip of my cervix will be, but you can see I do believe that the anterior lip actually probably starts a little bit lower than my seed did, right? But so here's my cervix. You can see the cervix really well right here. So we're contouring. And again, the diameter, so the length is going to be 3 cms, right, of the cervix. The diameter of the cervix is what you feel at the time of your implant, right? So that's really important. So in this case, we felt that the cervix was about 3.5 to 4 cms. So you can see my diameter, so let's measure this, is exactly like 3, right around 3. So it's important that you know what your diameter is, because people tend to over contour on the CT. So it is what you feel, right? So if you feel a 4 cm cervix, then your diameter is going to be 4 cms, right? And if you feel a 3 cm cervix, then that's what your diameter is going to be. So I'm going to let Christina continue talking, and then I'll be right back, okay? So Christina is my dosimetrist, and she's going to continue talking about step by step what we're doing, and I'll be right back.
Normal tissues. Okay. Hi, I'm Christine. I'm one of the dosimetrists that works with Dr. Jhingran. And so she was talking about the diameter of the HR-CTV. So starting here inferiorly, again, we want to make sure we get the anterior lip, which is a little bit inferior to the seed. And here is a seed. Right here on my cursor, I can delete that blue line or move that blue line out of the way so you can see the seed a little bit better. So as we're coming up superiorly, trying to see if we can get that seed in view. You can kind of see it in the sagittal view right here. There's a little bit of artifact right in front of the tandem, and that would be your anterior seed. So we want to make sure that the seeds are within our contour as well. Now with this case, as we go up, here's the posterior seed. Just let me get that into view sagittally so you can see it here. So it may have gone in a little deep as we're going up, and some of that is a little bit of artifact too, because they are platinum seeds. So they put 2 in. Probably they thought one of the seeds went a little bit deep, so there's 2 seeds here is what you're seeing in the axial view.
Hey, Christine, this is Michael. I'm a physicist.
Hi.
At what point are the platinum seeds placed?
So with our patients right now, if they're doing pulse dose rate or HDR, we're putting them in their first insertion. So they'll put the Foley bulb in, And then usually they'll put a speculum in and they'll place the 2 seeds. So we have a seed inserter, and that has like a hub about a cm deep, and they can put, it's kind of like darts, they can put the seed in at the 6 and 9 o'clock position. And then after that, then they proceed to sound the uterus.
Okay.
And
good.
I'm sorry?
Because the 3 centimeter in width at the the supinf orientation around the os is obviously, looking at your actual slice, is not symmetric about the tandem, so it's much more posterior than it is anterior. So, and obviously, as a physicist, I'm not the one contouring, but I want to make sure that my physician draws proper volumes. So that's why I'm asking. The asymmetry, if you don't place seeds, you go by CT, what you see on CT?
What you see on the MRI.
Okay.
Because you can't really see the cervix on the CT, and so that's why they always try and get the MRI scan close to the insertion. And they can really, they'll have like the MRI open, and they'll just cognitively draw the HR-CTV on the CT that they're doing the implant, and just kind of look and make sure. So they'll do some measurements on that MRI as well to help guide them.
Yeah, okay.
But the seeds are mainly just for the anterior and posterior, not really the width. So the width, they just go based on feel, what they feel in the operating room.
Okay.
All right. So so those are the seeds. So as we go up, I look at, she was saying she doesn't really use the coronal, but it's kind of nice to have the coronal in view because you can just make sure that you're staying symmetric on both sides as well, as best you can. So as we're going up, so what it ends up, they know that the cervix kind of goes in a conical shape. So what they're trying to do now is try to taper off and make it more conical inferiorly. So let me get the sagittal back in view. So as you can see, as they're going superiorly up the tandem towards that 3 cm, they're going to start bringing it in and making this conical shape. So it'll be, your contour will look a little more posterior than anterior as you're going up the tandem. So it starts anteriorly down at the bottom to get the anterior lip. And then as you're going superior, you start to taper off anteriorly and just contouring posterior cervix to create the conical shape. Any questions about the HR-CTV? So it's making sure you get the anterior lip down right at the cervix and creating whatever the diameter of the cervix is, 3 to 4 centimeters wide, so you don't get too wide here. And then again, this is also based on per patient, and then just creating more posterior conical shape towards the top.
Quick question regarding contouring when you use ring and tandem.
Okay.
I've seen contours drawn that included the ring structure itself, and they maybe spilled over it posteriorly more. And what do you guys do for tandem rings?
We definitely. So you're saying that the contour goes into the applicator?
Yeah, the applicator.
Oh, yeah, that's not correct. Yeah, we always make sure that, because that wouldn't be your target, that would be applicator. So you would never want to contour any, whether it's HR-CTV or any critical structure, into the contour itself. Another way, I know sometimes it could look like that in the axial, so that's another reason that I use the sagittal view. And I'll try and get, like with this case, if you look in your sagittal view, you can see the edge of the ovoid cap here. And you can do that same view with the ring. And sometimes, even when we're just going through the initial contour, we'll be like, oh no, we got it into the ring cap. And you just go in and you take that contour out. We would never leave that contour in.
Okay.
So I think that this coronal view is helpful for that. You know, and mainly when you're contouring, you would look axial and sagittal, and then, of course, you know, you can scroll through coronally, you know, using all 3 dimensions to just double check and triple check.
So considering, like, if you were to review many cases that you've done in the past, and obviously Oncentra gives you a volume for your high-risk CTV, and
Yes.
since it's based on geometric considerations, do you have a rough number in mind as to what your volume would be? Here it's 19.4 cc's. If you saw something like 50 cc, you would be highly suspicious that that's incorrect, that is overdrawn, that it's way too large.
Yeah, I usually, I haven't specifically looked at the numbers, but visually I can tell if it's questionably been over contoured, and I will have, you know, if a resident has come through and done, you know, the HR-CTV, and I thought it looked rather large in some areas, I would bring it up to the physician and have the MRI, their MRI, the one that was closest to the implants as possible, so we can really see what the disease is and have them looking at that to make that decision. But as far as a number, I don't really have a range. I haven't looked at that. I should probably start noticing that and see if they correlate. But again, sometimes we'll have patients that have a tiny cervix and no disease, and so their HR-CTV would be a lot smaller than someone that had a 4 cm cervix and lots of disease. So it varies. But I can start looking at the number, and I can maybe next time let you guys know.
Okay.
Any other questions about HR-CTV? I know she briefly went over the bladder. I guess we can talk about rectum and sigmoid. So mainly, another thing I don't think that she had mentioned is, especially with these ovoids, you can see that it gives off a lot of artifact, and sometimes we have to use the sagittal view to really kind of see the separation from the bladder and the ovoid. So I really, if you are using shielded ovoids, it's nice to kind of scroll here, because we're mainly, this is, you know, volume implant. We're basing it on the 2 cc's of the bladder that's closest to the implant. That's going to give us our hottest dose. So I really try and make sure that the posterior edge of my bladder is the most accurate. So I will scroll through the sagittal and just make sure all this posterior edge here looks reasonable, especially up against the ovoids itself and up here at the cervix, where we're going to really be trying to get the most dose. So we notice usually with the treatment plans that, you know, this posterior edge of the bladder is that D2 cc's. And then on the opposite end, in the rectum, I'm mainly making sure that that anterior portion of the rectum is as accurate as possible. And again, I'll try and get a better view in the sagittal. As we're going through in the axial slices, not only am I looking here when I'm doing my contour, but once I've gone through that final few slices, I will come here in my sagittal, and again, making sure this anterior part of the rectum is as accurate as possible. So again, using axial and sagittal view is really crucial through this. And then again, if you want to check your coronal just for symmetry, you can see here and just making sure you get the width correctly. But again, just like bladder, posterior bladder is going to be where you're getting most of your dose, and anterior rectum is where you're going to be getting most of your dose. So that's where I'm really trying to make sure I'm accurate as possible with the shielded ovoids where there's artifact. Okay, so Dr. Jhingran's back.
Quick question, Christy.
Yes.
Obviously, in your sagittal view right there, it's a reconstruction artifact that looks like air, but it's not. So
yes.
what? I mean, I've seen lots of cases where there's a big gas bubble right behind the ovoids or right behind the ring that is there during the time of simulation. How do you deal with that? Because that's very likely not very reproducible. The patient
Yes.
may have passed gas in the meantime while you're planning.
Yes.
How do you deal with that?
Well, we can ask the therapist to insert a rectal balloon to try and get rid of some of that air. If we're doing with HDR, you can do that and re-stim them and get a new scan if it's a large air bubble, but we would include it in the contour unless we're going to do a re-image. But we would know.
If anything, it's a worst case scenario. By the time you treat, that bubble may have either been reduced or might be completely gone.
Exactly.
And then your rectal dosimetry, if anything, will improve.
Exactly.
I would think.
That would be worst case scenario. You're right.
Okay, thanks.
You're welcome.
Hello. Sorry, I know she's gone over everything. So I'm going to show you the plan. So let me show you the plan. So here's the plan. So this is our plan. And so look, you're going to look at our doses, but these are not real true HDR doses. These are PDR doses because that's how we treat it. But I want you to convert it to HDR because that's what you guys do, right? So let's just look at our doses. So first of all, let's just look at our sagittal plan. So here's our sagittal plan, and I like to look at my sagittal plan. So the red line is my prescription line right here. Okay, so that's my prescription line. As you can see, because that bladder was so full, you can see it is really going into my prescription line. You can see that's 45 and 56 gray, right? So the bladder you know is going to be hot. And that's the advantage of HDR. So I know that this bladder is going to be hot, so that's one fraction. So then I can go back the next time and make sure that I empty the bladder or see what I can do to make sure that the bladder is not as hot the next time, right? The other thing that is hot, as you can see here, and I think that's what you asked Christine, is the sigmoid. And that's so crucial with HDR. Really interesting, with low dose rate, we never saw any sigmoid complications. And I think it's because the sigmoid moved the 48 hours or the 72 hours that you had the implant. With HDR, it's not moving. This is static, right? So this is the true dose that sigmoid is getting. So sigmoid is so crucial, and it's actually more crucial than rectum is for HDR. Now, and you're asking her, this is really full, what do I do next, right? So one, I would, definitely you have to tell her, do, some kind of enema, make sure you empty your stool, make sure your stools are empty, that would help your sigmoid dose. Not eat for a certain point before the treatment could help. But there's multiple ways to try to see if you could get that sigmoid to be empty. But you can tell that my sigmoid's going to be hot and my bladder's going to be hot. And if you look, my HR-CTV, 90%, which you're going to look at 90% of the HR-CTV is getting actually a decent dose. 51, which would probably correlate if you were doing 600 to be about 650 to almost 700, right? But you can see my 2 cc bladder is getting 40.52 centigrades per pulse. So that's hot. It's almost the same dose as my HR-CTV. My rectum and my sigmoid, so we already talked. The sigmoid is going to be hot. The sigmoid is hot. But it's much better than my bladder. And again, nice thing with the high dose rate is, okay, so this is bad. Next time I can do better, right? And that's what I'm going to do. My rectum is great. So I'm not even going to worry about my rectum. Next time I'm going to make sure she has an empty sigmoid, and I'm going to try to really empty that bladder to see if I can reduce the dose of the bladder. Questions?
How many times do you say that, oh yeah, I'll do better next time, say fraction 2?
Oh, I don't.
2 turns out this turns out as well. Yeah, I can do better on fraction 3.
No. Right, no.
How far do you follow that rabbit hole?
2, and if it doesn't work, then the third time I will either repack or figure out what else I can do, right?
Okay. So
right, I mean.
Run out of options.
Then you're in trouble, and then you hope and pray. Like I'm going to tell you right now, I have one that I'm doing HDR right now, and the bad part is that she had perirectal nodes, so my external beam is already taking it to 50 gray, almost 48. So my sigmoid's getting full 48, and I'm going to tell you, my sigmoid, if I do the same brachytherapy dose, my same my brachytherapy dose 5 times, her sigmoid will be at 8,000. And you know what? I'm going to have to suck it up, and it's going to be at 8,000. Because if I don't get that dose to her tumor, she's going to recur. So, I wish I could have, in fact, that's a great case for me to show you but that's why actually the new Embrace is really telling you not to take your external beam past 46. Because, so many people are going to 50 with their external beam because of the tandem and ring, because they're not getting their HR-CTV dose is high enough, right? And so Embrace really, but problem is you're doing 50 gray with external beam, you've already limited your brachytherapy dose, right? Because that sigmoid's already seen 50, the rectum's already seen 50, and your bladder's already seen 50. So then you're limiting your dose with your brachy. So new Embrace tells you to stop at 46 at the highest with the external beam. I unfortunately this is actually a great case, and I really need to show it to you because you're right. I've already hit 48 with my external beam. I'm not going to win, and her sigmoid is stuck. So what I'm going to try to do next time, but I know I'm not going to get less than 50. I know my sigmoid is going to be close to 78 by the time I get done. And she is getting high dose rate. But, there I say, what am I going to do? Either I don't treat her tumor, which is really bad, or I kill her sigmoid, and I may end up having to kill her sigmoid. I'm gonna suck it up and go to at least 75 to 78 to the sigmoid.
Yeah.
I don't have a choice. And the problem is she's actually an ex-drug addict, so she's even got higher complications. She's got Hep C, so she's got even higher complications probably with bleeding, rectal bleeding, and sigmoid. But to get my HR-CTV dose, and she's got bad disease. She's got nodal disease. She's got bad disease. And my sigmoid will be close to 75 to 78 when I get done. Then there's nothing I can do about it. Nothing.
Quick question. Looking at the sagittal view, would you potentially consider adding a couple posterior needles?
Yes,
this was
exactly. 100%. 100%. And that's what Embrace is doing now. Right? 100%. This is a case where I would put posterior needles in. So that's the other thing that you can start. That's 100%. That's what I would do in this case. And that would save some of my sigmoid and my rectum. And this lady that I'm not, even the needles won't help, right? Where I'm putting the sigmoid so high because I've already taken it so high. But in this case, the needles would definitely, this is the perfect case where you would put needles in. And that's where Embrace tells you to put the needles so that you can save that normal tissue. Yeah, exactly.
Very good.
Yeah, exactly. And in fact, I have a great case. I have we've just done a couple of very cool cases. We've done one last week that we did with the Venetian that we put needles, and you can see, and the needles really help a lot in reducing your normal tissues. Other questions? Any other questions from anybody?
I do have another one.
Yeah, no, please ask. That's what I'm here for.
So regarding needle placement, what policy at MD Anderson are you following in terms of needle placement? We started using needles, but it was shut down pretty quickly because they were not placed in the OR. In case some medical event happens in radiation oncology in our CT/HDR suite, and for like side template implants, sometimes when you image, you take your CT scan, you simply have to either take some needles out that were even going into the rectum, or or you have to place 2 or 3 more needles because you don't have your target covered, and then your whole needle implant is really useless if you can't reach where you need to go be. So but when would you make, like in this case, if you had to make the decision, I really need a couple, 2, 3 posterior needles or 4 to cover this, would you place it right there? Would you? So in this case,
in this case, I would actually do it the next session, right? Because so we would do it in our CT suite. Or we're doing it in our MRI suite, because now we have an MRI suite where we're putting all our needles, right? But either the CT suite or the MRI suite. But can I just say, so that's our policy. So what we would do is we would have looked at this, and this is one case that we would say, okay, 100% of this patient needs needles, so the next one we'll put needles in, we'll put it in our MRI suite. But San Diego, they actually will put needles. She puts 1 or 2 needles in every case, and she uses it or not uses it, depending on if she needs them. Right, so that's another option. I think that's a little bit too much, right? But so the way San Diego does is that they put needles in, then they do a CT. So they do that in their OR suite, and then they do a CT scan. And then in the CT scan, they'll either pull, if they need to pull out, they'll pull it out in the CT scan, or they just leave it even if they're not using them. Mm-hmm. I know. So and this, what we would do, and that's what most people do, is they'll do the first case, or if they have an MRI, they already know. Like most of the time, like I said, I always do an MRI my 4th week into treatment to see what the disease response is, and then we could even decide if we need needles or not, right? So that's helpful. But the other thing is you do the CT scan, and the first case the first HDR you see, do I need needles? Yes. So the next one, I would put needles in, and the third one, I would put needles in. But then you can see, is it responding? If it's responding, maybe you don't need it for the 4th or the 5th, right? And that's the other thought, is that as a tumor shrinks, like in this case, as a tumor shrinks, maybe I wouldn't have to go so posterior, right? And you're hoping as you're going between your brachytherapy systems, you can do it. But we do it in our MRI suite, where we do have anesthesia when we're putting the needles in. So, but we do it in the suite, and we would do it in our and we have a CT suite too, and we get anesthesia to come in there as well. So we could do it at either or, where we could put needles in, and that's what San Diego does too.
Okay.
Can you get anesthesia to your?
Yeah. I think the hang up is like, and maybe offline.
Yeah.
If you guys have the problem is, what if something happens to the patient? Can you get folks there, stat, to assist? And the idea is that you can ideally,
we're in
best help, the best help you would have in an OR setting, and that's why it was put on hold here.
Oh no, I could tell you,
it was forbidden that needles.
Yeah, no, we should talk. Yeah, we should talk, because where we're putting needles, we're like in the basement that nobody could find us.
Yeah. Okay.
I mean, nobody.
Mm-hmm.
Yeah. Definitely. Let's talk offline, and we can send you our policies. But I mean, I'm telling you, San Diego does it. Puts needles on everybody, and they will. And I think sometimes they get them in the rectum and stuff. Key is, if you don't treat it and you see it and you withdraw, you're fine. You shouldn't have, besides bleeding. Now, bleeding would be a big issue, right? But other than that, you should not. I mean, even if you're in the rectum, if you withdrew and don't treat, you're okay, right? Yeah, and that's a policy. As long as you see it and you don't treat it and you withdraw it, you're okay.
Yeah. Plus, if you don't place needles, I mean, you're doing your patient a disservice.
Right. Yeah.
You're really not treating the volume that needs to be treated.
Right. I mean, like I said, I'm going to kill my rectum on my patient. I mean, my sigmoid. But in her case, I don't think the needles are going to even help. But in this case, a needle, this one that I'm showing you right now, a needle would be the perfect solution. So yeah, we should definitely talk offline. And I'll tell you, because we're like really in the middle of nowhere. I don't think anybody could find us if we had a problem. It's scary. Any other questions? Definitely call me offline, and they know how to reach me. I have a cell phone. Call me, and we can send you all our policies and procedures. And this has actually been passed by our Medicare department. We've had our Center of Medicare Service come down, and they've approved all of this. So definitely, we can send you everything that we're doing, and our, what have we justified.
I have your contact info. We were in Accra together last year, remember?
Ah, okay, yes. Yes,
Thanks.
yes. All right. Thank you, everybody, then. No more questions. All right, then have a great day, everybody. And let me know if anybody can email me and talk to me, and we'll get things going. I appreciate it. Have a great day.
Thanks, Anuja. You too.
Okay, bye.
I just wanted to tell everyone, too, that we'll be sending out the post-curriculum assessment. So just keep an eye out on your email and on your WhatsApp, and I'll send that over to everyone. And if you complete that, they'll be a part of the certificate you'll get at the end of the course. But yeah, I think that's it. Thank you, everyone.